basic triage system. And how about in Philippines? Yeah. Sometimes a lot of the triage models in the world can be used. Yeah, but in Indonesia still use, but it is some of the hospitals. Yeah, because the system adapt the disaster triage system. Yeah, the namely is the start, simple triage, and rapid treatment. The category that is black, red, yellow, and also green color. Black is for the dead patient, red color for the emergency patient. That is airway breathing and circulation disorder, and yellow when they can be delayed. It is for the classical triage system. What is the purpose or objective? The main goal is to identify life-threatening condition. Yeah, so to prevent of the uh, a lot of number patient when they come on uh, admit in emergency department, identify which one is the most priority based on the urgency. Yeah, the second goal is for prioritize patients according to their severity. It is one of the consideration in stress patient. The categorization may be determined at any time, but if in doubt, yeah, sometimes we are confused whether is patient in what level, yeah. For example, patient with the sepsis, yeah, whether this patient is level 2 or level 3 or also level 1. So if in doubt, we select the level patient is up triage, yeah, to avoid decreasing triage. So when we select the up triage, we will focus on in-depth evaluation for a patient to prevent of the worst condition. Yeah, for a disaster, it is one of the triage in individual patient in hospital to provide the best possible care for each individual patient. But for the disasters, to provide more effective treatment for large number of patients. It is the difference between triage in hospital and also triage in disasters. Yeah, so a process in which patients are classified according to the type and severity of their condition is to get to the right patient to the right place and the time and the right available of care. It is one of the objective when we give the triage for hospital. Okay, yeah. It is one of the assessment that can be used to assess whether this patient what level, yeah, based on the level of urgency, yeah, yeah. You can assess the urgency of the patient's condition. Urgency is different from severity. Yeah, patient can be categorized as having non-urgent condition, but still requiring hospitalization. Another one is how long patient can wait or offer waiting time. Yeah, a long patient can safely wait to get treatment in the emergency department. The triage system is not designed to make a diagnosis, but it is measuring for the life saving can be started simultaneously, such as airway clearance, external heart message, and then direct pressure on the source bleeding, cervical colon insertion. It is one of the some assessment when we assess patient when they admit in emergency department. So triage is an interesting challenge and specialty of emergency care. So for the nurse who can get job of the triage officer in hospital, the nurse leading to the triage it is the authority of the nurse to triage the patient independently. Yeah, it is the independently function from the nurse to make to decide which is the patient what level and not depend on another health profession. The triage nurse makes the final decision on triage. Only nurse who have special education are allowed to do triage. Yeah, there is some of the training for the nurse, not only graduate from the university, but they must take some course, yeah, to get some of the knowledge about the triage. Yeah. Why should a special trained nurse be allowed to perform triage? In determining the category requires competence and clinical judgment. Based on the experience, the nurse who have a lot of experience in emergency department, they can predict about the next condition patient. Yeah, and then we can predict what of there will be what will happen with the patient will if we delay for give the life-saving intervention. So based on that, a lot of experience we can give the or decide about the level of triage. Yeah, it is a lot of the sum of models triage in the world. Yeah, the hospital triage method, which is currently being developed and has been extensively researched on its reliability, validity, and also the effectiveness. Yeah, a lot of model from the first from Australia. We call it the ATS, yeah, Australia Triage System. It is one of the model that be used in Indonesia. Yeah, a lot of hospital use this model to triage in hospital. Another one is the Canadian, yeah, we call it the CITES, Canadian Triage Equity System from the Canada. Another one is from the United States, yeah, Emergency Severity Index, yeah. I will when I visit a lot some of the hospital when I study in Thailand, yeah, and also when I visit in Malaysia, a lot of hospital in Thailand they use these models, yeah, using the emergency severity index, yeah, almost similar in Indonesia. In Indonesia, a lot of hospital using these models, EC and also for the ATS. Another one about from the Europe, yeah, for Manchester Triascan. Ini also another one like from Korea, yeah. We have like a Korean Triascale, from Taiwan also Taiwan Triascale, and a lot of the model from the some countries, yeah. It is the triage category based on the model of triage. For SC, to decide we use the level, yeah, level 1, level 2, level 3, level 4, and level 5. But for MTS, yeah, Manchester just scale, this one using the colors, yeah, on the red, orange, yellow, green, and blue. For the CITAS level using like this: resuscitation, emergency, urgent, semi-urgent, or not urgent. And then the ATS using the overtime waiting patient for white get the life saving, whether the immediate life threatening or can be delayed. Okay, yeah, it is one of the triage that we adopt, yeah, adopt in hospital. Yeah, the first, the triage nurse is guided to see the condition and severity without having to wait for doctor's intervention. It is one function of independently the nurse to decide about the level of triage. The second reason is consideration of resource, yeah, for the SC models site use the condition patient and severity without having to wait for other doctor's intervention. We consider of resource of usage, yeah, number of resource usage for patient to estimate bed utilization. The third one is the system emergency severity index use a band scale, yeah. So the band scale, if the patient have score more than 7, yeah, we give the level test in level 2, yeah. Okay, yeah. Okay, in the emergency room the system has many versions in Indonesia. Some hospital they modified and also modified from the originally of the triage model according to condition in each hospital based on the patient in the countries, yeah. For the AC, yeah, emergency severity index, and also for the PACS, Singapore Patient Acuity Category Scales, and also LTS is the most widely adopted and modified in Indonesia. Yeah, based our observation in lot of hospital, the most of hospital in Indonesia they use in three models. Yeah, some AC, PAX, and also for the Australia. The selection paradigm based on diseases diagnosis has begun to be abandoned, yeah, because it is prone to delays and mistriage. So it is cannot we keep the level of stress based on the medical diagnosis. Yeah, this the okay. We try to learn about the first model is PAX. Yeah, how about the PAX one? Patient Equity Criteria Singapore. This model is from the Singapore. Some hospital in Indonesia they use this model. For example, is some of hospital in Indonesia they use model. Yeah, for the PAX one, it is for a patient category who are experiencing cardiovascular collapse or in a life-threatening condition. Helps in this category should not be delayed. Immediately we give intervention. For example, is the patient with the major trauma, as the elevation myocardial infarct, and also for the cardiac arrest. About this condition, we should give the intervention life saving, cannot be delayed. Yeah, it is for the PAX one. And about PAX two, level two, if there is a the categories of patients who are seriously conditioned, yeah, they can sleep on the stretcher or the bed and are in severe distress but hemodynamically stable on initial examination. Yeah, for the PAX level 2, the hemodynamically is stable. Issue priority for second aid or close supervision because they tend to collapse if they don't get help. For example, for the PAX 2 is patient with stroke. Yeah, because if the patient admit time is more than 3 hours after the first, so it is can make the some of the disability or another one. So it is the PAX two. Yeah, for example, another case is closed long bone fracture and etc. And then for the PAX three, this category of patient is acute, moderate, able to walk, and not at risk of collapse. Yeah, helping effectively in the emergency room is usually enough to eliminate or improve the patient's complaints. Yeah, for example, patient with the fullness, yeah, fever, mild, moderate injuries, and others. Yeah, yeah, for fever. But we still remind about a few years ago about the pandemic COVID. Yeah, about the pandemic COVID when patient admit in hospital with complaint of the fever, sometimes of the cough, yeah, it is one of the consideration to select whether this patient must be prioritized or not. We have some consideration to prevent of the spread microbacteria to another patient or to the nurse in emergency. It is one of the considerations. So this model triage cannot be used during the pandemic, yeah, in hospital. So in Indonesia, some of hospital they use two models to triage of patient. Yeah, one the first is patient with the COVID, and the second one is patient with non-COVID. Yeah, so it is one of the limitation that these models in hospital. Another one is about the PAX 4 is a category of non-emergency patients. Yeah, it is the false emergency. The patient can be treated in polyclinics or on the um, medical doctors. Yeah, not come to the hospital in the emergency department. The patient does not need immediate treatment and does not have a life-threatening disease. Yeah, it is for PAX 4. Okay, so for the triage model in PAX, we divide in 4 levels. Yeah, for the PAX one, PAX 2, PAX 3, and PAX 4. How about the another models from America, from United States? Yeah, the namely is the Emergency Severity Index or AC. The system developed in the United States and Canada by the Association of Emergency Nurses and Emergency Specialists. For these models, the level of triage is divided in life priority scales, like in this slide. Yeah, it is one of the figure of AC triage system 2004. We can see from the this figure, right? We can ask about the patient whether this patient requires immediate life-saving intervention. If yes, so this patient in level 1. If no, no need immediate life-saving intervention. So we ask about the condition. It has high risk situation or confused, lethargic, or disoriented, or patient with the severe pain. Using the numeric rating scale, the pain score is start from 7, 8, 9, and 10. If yes, so this patient in level 2. If no, another consideration to decide whether this the patient, we can check for the fatal sign. Yeah, if the patient in danger zone vitals based on the age, yeah, from the last 3 months, 3 months to 3 years, 3 to 8 years, and more than 3 years. You can check from the heart rate, respiratory rate, and also for the saturation of oxygen. If the assessment of vital sign in this during this area, danger zone vitals, so the patient considered to level 2. If no, it is the level 3. Yeah. And the last one to determine about this model AC is we can ask about the how many different results are needed for a patient. If a lot of research are needed for a patient, if yes, many, we can give the level 3. If only one, we give the level 4. If no one, none of resources are needed for a patient, if the level 4, level 5. Yeah. So for the AC, if patient with come to the hospital with the level 1, level 2, and level 3, this patient in true emergency. But for the level 4 and 5 is not true emergency or false emergency. So about the research are needed. What is the research are needed for a patient? This one, yeah. You can check what is the difference. It is the resources or not resources, yeah. For example, when the patient admit, we need the laboratory, for example, blood, urine, yeah, ECG, X-ray, CT scan, MRI, ultrasonography, angiography, and etc. It is number of resources, but it is not a resources for example. If patient need the history and physical assessment, yeah, it is not a resources. Yeah. Another one like IV fluids iteration, it is of the resources. We can calculate how many patient need of the resources. Yeah. So you can give the third consideration if we using in using emergency safety index. Okay, we try to learn the deeply about the this model. But priority one about the AC. In this the original model for the AC, the color is blue. It is for patients with impending life and limb threatening problem conditions that require immediate life-saving intervention. It is immediate life-saving, cannot be delayed. The parameters are all significant disturbance of airway breathing circulation and disability. Yeah. So when we assess the patient, if there's problem, the significant significant disturbance of the airway, it is the priority one. Yeah, for example, patient with the cardiac arrest. Yeah, the cardiac arrest cannot be delayed because if we spend of time more than 4 minutes after we find the patient, it is will influence on the percentage of patient can be survived. So we give the intervention immediately. Yeah, and then another one about the status epilepticus patient with the hypoglycemia. It is one of the condition. The second one is about the priority two using this model AC is red colors. Yeah, it is for patient with potential life, limb, and organ threatening problems. So the treatment for this patient is urgent and cannot be postponed or cannot be delayed. The parameters for this level 2, yeah, the parameter is hemodynamic step or stable air repeating circulation disability with decreased consciousness but not coma, yeah, severe stress and headache, yeah. For example, patient with asthma, yeah, and then acute abdomen electrical injury. It is one some of the example cases for the patient in level 2. And then the level 3. Level 3, the original model using the yellow color. Yeah, it is for patients who require in-depth evaluation through clinical examination. In-depth evaluation. Yeah, and then patient require two or more. Yeah, and, resources are needed in hospital. Yeah, priorities 3 to 5 related to resource requirements. For example, patient with the sepsis. For the patient with the sepsis, yeah, septicemia, yeah, they need some resources like laboratory, yeah, ECG, Ronsen, and etc. So, if we see from this condition, it is patient in priority 3. But if the patient with sepsis of severe sepsis, it can be considered to priority 2. But if the sepsis has been shock condition, it can be of the priority 1. Yeah, it is based on the condition. So even though in sepsis patient, but the condition is different. So we can use select for the atrias. Yeah. Okay. And then for priority 4, it is for yellow also, yeah, similar with the priority 3. It is for patients who need one kind of emergency care resources. Yeah, for example, patient with PBH, yeah, benigna prostate hyperplasia. Yeah, for these patients, they requires a urinary catheter installation. Yeah, and then for the patient with fulness laceratum, they require simple hacking and etc. Yeah, it is for the priority 4. The last one for the priority 5, the original color using the white label. It is for patients who do not need resource or patient with fast emergency. This patient only requires a physical examination and anamnesis without supporting examination. The treatment is generally per oral or treat simple wounds. For example, patient with common cold, exorization, and etc. Yeah, it is from the patient in priority 5. And how about the difference between all these models? AC divides emergency into parameters, namely the ABCD, airway breathing circulation disability disturbance parameter, and also the resource of parameter. Ongoing disturbance of airway breathing circulation disability receive first priority, while indirect disturbance and ABCD receive second priority. Yeah. The more resource needed in the management of disease, the more serious of the disease. Yeah, it is for the AC. Okay, on the last model, it is the Australian triage. Yeah, Australian triage divided in 5 levels. Yeah, it is using the time. Yeah, how long patient can wait until they get the life intervention. Yeah, For the ATS one or priority one cannot be delayed or immediately. Yeah, 0 minutes. The waiting time around 0 minutes. For example, patient with the cardiac arrest. Yeah, cardiac arrest cannot be delayed. Yeah, patient is apnea. Yeah, stop breathing or apnea. Patient with the obstruction in the airway, and then respiratory frequency or respiratory rate less than 10 times per minute, and then distress or breathing difficulty, dyspnea, yeah, that are very heavy, this very extreme. Blood pressure for adult patient less than 80 millimeter hydrogium, or shock in children or infant, yeah, and then not respond or only respond with using the pen with the Glasgow Coma scale less than 9, and then the continuous or prolonged seizures, intravenous overdose, and unresponsive or hypoventilation. Yeah, one of the another condition that can be used this model is patient with the psychological disease. Yeah, yes, the severely disturbed conduct with the harmful. Yeah, this one of the model that can be used in psychological hospital. Yeah, imminent death, harmful violence. Yeah, violent. This one of the this model. So for the Australia, can be used for the general hospital and also for the psychiatric hospital. Yeah, some of the psychiatric hospital they use this model because the assessment not only for physical but also for the psychological. Yeah, it is different with the patient also for the uh, AC. And then for the next level is level 2. Yeah, level 2 using the Australian triage. The waiting time around 10 minutes. Yeah, it is for patient with airways risk, severe stators. Yeah, like some of the obstruction the airway, partial obstruction, and dangerous axis, saliva production, distress or severe breathing difficulty, and then cardiac chest pain. Yeah, cardiac chest pain is the level 3. The pain is intense regardless of the cause, and blood sugar level less than 2 millimole per liter. It is one of the cases in level 2. Another one about the drowsiness, decrease of responsiveness for the KGS, yeah, Glasgow Coma scale less than 13. Acute hemiparesis or dysphagia, fever with signs of lethargy, eye contact with acid or alkaline substance, require of irrigation in the eye, and then major trauma, multi-trauma requires rapid response from an organic team, severe local trauma, yeah, for example, is fracture or amputation, history of high-risk disease, significant consumption of sedative or other toxic substances, significant or hazardous inflammation, severe brain sixting, preeclampsia, abdominal aortic aneurysm, or ectopic pregnancy. Behavioral abuse of aggressive directed to self or other requires restraint. And the last one is the severe agitation or aggression. Yeah, it is some of the detailed cases in level 2. And then for the level 3, yeah, the waiting time wait until 30 minutes. Yeah, it is for patient with the severe hypertension. Yeah, for patient with the severe hypertension, it level 3. Losing of amount of blood regardless of the cause, moderate shortness of breath, oxygen saturation less than 95%, yeah, and then blood sugar level more than 90 millimoles per liter, history of seizures, all fevers in immunosuppressed patient, oncology patient, steroid reaction, yeah, continuous vomiting, dehydration, head injury with brief loss of consciousness, currently conscious, yeah, and then moderate to severe pain. Whatever the cause, they requires a analgesic. Yeah, it is for the ATS level 3. And then for RTS level 4, the waiting time until 60 minutes. Yeah, between Australia and Canada, it is almost similar. The difference in the level 2 for the Canadian triage model, the waiting time for the level 2 until 15 minutes. Yeah, it is for the Austral is 10 minutes. Yeah. Okay, for ATS level 4, it is for patient with light bleeding, chest injury with other pain or respiratory distress, yeah, and then difficulty swallowing without respiratory distress, minor head injury, no loss of consciousness, moderate pain with several risk factors, vomiting or diarrhea without dehydration, inflammation or foreign body in the eye, and then the minor extremely trauma. Yeah, it is one of the cases until 1 hour. Yeah, 60 minutes. And the last one is for the ATS level 5, the waiting time until 2 hours or more. For example, in patient with the minimal pain without high risk features, and then history of low risk disease and currently asymptomatic, minor symptoms or existing stable disease, minor symptoms of a low risk condition, minor wounds, minor appreciation, minor laceration, and schedule control for example on wound control, complex appendix, and etc. It is one of the cases. So only control complex appendix is not admit in hospital in the emergency department. Okay, yeah. For the classification system, use numbers, letter of signs, the priority one or emergency. Yeah, patient with life-threatening conditions require immediate evaluation and intervention. The patient is taken to the resuscitation room. Yeah, after we triage the patient, then patient placed on the resuscitation room. Waiting time is 0 minutes. Yeah, immediately. Okay, all significant disturbance on the PCD. Yeah, okay. Priority two, patient is urgent. Yeah, patient with acute illness may require truly wheelchair or working waiting time until 30 minutes. Yeah, clinical care area, and then hemodynamically stable in LPCD patient with unconsciousness but comatose, glaucoma scale 8 to 13. Yeah, and then the fourth sample is asthmatic. Yeah, acute abdomen, electrical injury. Yeah, level 3 is non-urgent patient who can usually walk with the minimal medical problems. Or once this condition has existed for a long time, ambulatory area. Okay, yeah, level 4, case of death. Yeah, no response to any simulation, no spontaneous, no evidence of cardiac activity. The patient is not pulse when we pulse in the arteria of uh, carotid. Yeah, loss of pulmonary response to motion. Yeah, sign of brain. It is one of the MOTS. Okay, it is for the color that like in this international color code in Trias, black, red, yellow, and green. Yeah, it's on the level. Priority zero is for the jet patient. Yeah, involve correct question technique to obtain. Sometimes in hospital we use the look assessment because if we assess a lot of time to detail, it is more make the patient is full. Yeah, in the hospital. Yeah. Yeah, okay. So sometimes you usually like look assessment. Means a careful assessment of objective data requires nurse who are able to think critically in determining priorities based on that. Yeah, yeah. It is one of the triage assessment with the SOAP system. Yeah, what is the meaning of SOAP system? SOAP system, subjective, objective. Yeah, okay. S is subjective. Yeah, it is one of the documentation to describe the study of using the SWOT system. Subjective data, objective data, assessment or analyze, and then the planning. Okay, subjective asks a question to find the chief complaint, mineral information, and symptom analysis use open question. Yeah, trauma cases for question. When it happened, how fast is the vehicle going? What is the is thing? Are you wearing protection? Did you lose consciousness? Yeah, this is part of the ask about the mechanism injury in trauma cases. And then for objective physical evaluation, patient appearance, observation data, vital sign measurements is the assessment about the temperature, breathing, pulse rate, blood pressure, yeah, and then oxygen saturation data from examination patient. Assessment analyze, revive, and evaluate subjective and objective data sets for then enforce priority and place patient according to the condition to the test more than continue if necessary. Interventions such as oxygen, spleen, and bandage. Yeah, it is summary from these materials. Yeah, conduct a system triage process. Yeah, so in hospital when patient admit when they come, we use the instrument is the primary triage. After primary triage, and then patient will get the intervention life saving. We can assess again using the secondary or tertiary of triage. Yeah, collect sufficient subjective and objective data, assess based on the patient's acute, plan appropriate intervention, and complete documentation. Yeah, for the legal consent, triage records must be sufficiently complete for a correct triage decision. Medical record is a legal document. It it provides a sequence of events. Yeah, it is one of the sample about the trust document like this, based on the color red, yellow, green, and uh, black. Yeah, okay, like this in Indonesia. It is for patient with adult patient. Yeah, like this primary survey using the airway, breathing, and circulation. Yeah, it is one of the example in Indonesian hospital. Yeah, for the documentation of triage. Triage documentation objective to support triage decision for communication of basic information to other officers. Yeah, and then for medical legal needs. Yeah, what must be documented? Yeah, the first is time. Yeah, what time patient come and we try to triage. And then chief complaint and accompanying symptoms, past medical history, allergy history, vital and band scale, subjective and objective assessment, and also the acute category. Okay, what do you document? Yeah, for the diagnostic test performed, interventions that have been given disposition, and then the evaluation and change in the patient condition. It is one of the key points. Yeah, describe the chief complaints as accurately as possible. Use words the patient can understand. Document things that make findings data difficult, such as the language barriers. Yeah, document any conflicts between subjective and objective data. It is one of the responsibility, the ethical responsibility. Every patient has the same right to get service in the trust process. Yeah, the decision, the patient's life depend on the triage decision we make. Yeah, so it is one of the first service when patient admit to hospital because the decision in will influence of the patient life. Yeah. Thank you so much. I think it's enough for these materials about the triage. And then for the next, yeah, maybe I will we need to discuss or direct to the another presentation, Mr. Satria. Okay, thank you so much. Before we uh,
Maybe directly continue to Butika, Pak Chanif,
okay,
because
direct.
yeah,
It's ready, yeah. Okay, thank you so much for the college, yeah, from Dominic, yeah, I think it's enough for me. And then we will be continue the next presenter from Unimus, yeah, Mrs. Dwi Nurmahtika, okay, because he is ready now. Thank you so much
Okay.
for me. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Waalaikumsalam
warahmatullahi
warahmatullahi
wabarakatuh.
wabarakatuh. Okay. Thank you for the time, Mr. Hanif. Good afternoon, guys. Mm, I'm the last speaker for this day. Hopefully, you are still enjoy this class before take a break and then continue for the last meeting. Today, I would like discuss with you all still related to the previous speakers about disaster about the trias, but for this time we have uh, different for the specific, yeah, we have different time uh, kind of the disaster trias. Mr. Hanif already explained or mentioned about the disaster kind of trias in the mass casualty or in a larger people. We call it a disaster trias. Um, because Mr. Hanif already explained very detailed and complete about the trias, so it's maybe he already understand very well about the concept of the trias. Yeah, the point is trias is process separating, categorizing, and classifying to take or to what's that to sort which one the person or people who need uh, treatment more than the others because it is in the mass amount or in the large people. So we really need the management to take which one that should be take first. Um, we have what that quote, not quotes, yeah, it's like like a definition, yeah. Triage is process how to uh, choose the right patient in the right place, yeah, to give the right treatment or receive. So it is a simple concept of the triage. Now we combine the definition of triage with the disaster. As we know that disaster is kind of disruption in the society, so causing widespread human, material, or environmental disaster. It can be natural, or it can be social, or come from any kind of a problem. But the point is, disaster is have a much or large victim. So the definition of disaster triage is how the medical respond from the situation by separating, categorize, or classify the multiple or massive number of casualty because they have limited resources. So it's very important to sort or to select which one the people or the victim that need to be treated first with the what is that resources that we have. Um, Absolutely, we should responsible and ethical manner possible. Um, Disaster triage can be conducted pre-hospital or in hospital. It's not about the location, but it's about the amount of the victim or number of the subject. Because disaster, it's mean that at the same time, at the same moment, we got a mass of patients and we have a limited resources, so we call it disaster. So when we conduct it in the pre-hospital, you can see from the picture, we make like what's that? A simple triage to chart the patient uh, based on their condition. But in the hospital, the situation is a little bit different because over there we have already divided the room based on the class of or the number. Um, this is I think that you already know about the kind of disaster. This is a natural disaster because from the natural disaster we got many people get trauma or they get this emergent situations. So for this one, sometimes or not sometimes, yeah, we do the uh, triage of disaster in the pre-hospital. But from the train accident or traffic accident and others, uh, disaster triage is conducted in the hospital. Mr. Hanif already explained kind of the triage, but in this slide, I would like underline my specific topic about the disaster triage. The differences is it is in goals. For the daily and incident triage, the priority is the patient who have bad or what's that worsen condition. It doesn't matter they have a high probability to life or not. But for disaster, we think not only about the condition, but we make sure that this patient have a higher possibility to life. Uh, because we have a limited resources, we have limited time, and we have as many or mass patient, the possibility to survive it's matter. Immediate care maybe cannot be provided because resources aren't available. So we should uh, what's that? Use the resources in best way. Based on the kind of these three trias, we can make a simple table to comparison the these two kind of the trias. Mr. Hanif already give you explanation about what should be documented in the daily trias. We have many things that should be write down or documented, but because in disaster trias we have a limited time with the amount of people, so the documentation will be shortened. We only put the name for the patient and then basic mechanism of injury. Of course, for the data of airway, breathing, and circulation, we this is the important thing that we cannot escape this one. And then also the vital sign and the level of consciousness, visual inspection, and sign of history. This is the point thing that should be write down by the nurse or medical team. For the another or other identity, name, gender, and etc., we can complete it after we give the patient treatment first. So from this comparison, you can get that for the disaster triage, we make a point, we only take a simple point, the important point that should be uh, understand well for the nurse or the medical team. Why? Because this data help us to sort patient based on their conditions. Um, the previous uh, philosophy, they do the best for each patient regardless of what it takes. But because nowadays we have many research and many theory have been developed, now the philosophy of Trias is shift from the to the best for each patient to be do the greatest good for the greatest number. So target for the disaster is not only help the patient, but how we get as much as possible patient or the people who get better by our treatment. So it's not only yeah, we can do the best thing for this one or this one. No, we can do best thing for the all of or everyone. So we get the greatest number for the patient. The shifting this philosophy is proposed to identify and reaching patient who have a good um, what's that possibility or probability to life. Mm, okay, sorry. Ah, to conduct the what's that the effective triage, we not only need a knowledge or we only need the experience, but we should have many abilities. This is list of the personal abilities to be a triage officer. Once more, because it is in the mass amount, or we face the disaster, we face a number of people who sick in the large number, not only the knowledge that we need in here or management. Uh, we also need the clinical experience, good judgment and leadership because our target that the greatest number of person who are our who get the treatment. And of course, we should calm and cool. Um, even we are must be hurry, but cool and calm it's make our knowledge or our cognitive is still well done, good and decisive. We should can make a good decision and knowledgeable of available resources. We should know well what our resources, because the point in the trias disaster, we should use effectively our limited resources with a much or large number of the people. And then this is maybe a little bit funny, but we need a sense of humor to make uh, what's that the medical team or the nurse not to stress out. Mm. And then the next is creativity is problem solver, because in this situation there are heterogeneity of the problem. We should take a decision as soon as possible. We should doing the best thing in the fast or in the limited time. And then available, and the last is experience and knowledgeable regarding anticipated casualties. Okay, so it is not easy to be a triage officer. Even we already learned about the what is emergency, what is the triage, what is what's that management patient with the emergency condition, but doesn't um, mean that we already what's that we already can be a triage officer, especially in disaster triage. Okay, nah, to short patient based on the condition in short time, yeah. Uh, for example, we have a 100 victim, and we should short them only in 5 minutes or 10 minutes. We need a model. We need a procedure. We need a rule. So we can short patient with the specific condition with the right thing with the right time. So I will give you some example, kind of the triage model for disaster condition. Mr. Hanif already explained about the triage, but that is applied in the hospital. But this kind of triage is mostly used in pre-hospital. Even the triage disasters is also conducted in hospital. For the child, we have different algorithm of triage. You can see from this time. Mr. Hanif already give you explain about the meaning of the color in child, adult, or in what's that? Mm, adolescent or in elderly. The meaning of the color is same, but the difference is in the process or the step. Yeah. In here, you can see that to the first time we can select the patient by the green first. So the people or the child who can walk first, they are included in the minor or the green color. After we short them or we separated them from the other victim, we direct to selected which one the color of red, black, and yellow. You can see from this algorithm. We sort the patient by the spontaneous breathing, from the respiratory rate, pulse, and the neurological assessment. To conduct this procedure, we only need in a time. It's not to take much time, but we should make a right classification from the patient. And this one, pre-hospital mass casualty triage tools. The previous one is one of the example that can be used for the pediatric. But for the victim of the disaster, it's not only the pediatric, right? We have many kind or large range from the age. For the all age, we can use the Sako Trias method. I already put the example in this slide. And then also we use the salt trias. In Indonesia, for some situation, salt is used, but mostly Indonesia use a start, simple triage and rapid treatment, because for some research they say that it is more simple, easy to be used, and effective to short patient based on their conditions. And then triage for the pediatric, we have jump start that I already showed you. And then for the second, we have the pediatric triage tape. And then for the situation or the patient that we don't know well, or we have no information about the specific their age, we can use curve like triage or triage shift. But it's rarely used. I don't know. Maybe for the research, this effective it's less than the others, or because another reasons. But I okay in this one. Okay. Um, I think that in my slide I tell you that mostly, and not only in Indonesia but mostly in another country, they use start, jump start, and salt trias, or some other use the Sako trias method. This one example for the Sako score. um, I don't know, but it's Indonesia ever use this one. But from my experience, I try to find out is that any city or department that ever use the Sako score, but I didn't find it. Maybe in the Philippines, um, the mostly people or the medical medical team, they ever use the Sako score. And this one a sample of the salt, that I said that in Indonesia it also use uh, short assess life-saving intervention and treatment. It also used to do the disaster triage. Some researchers say that it is effective. It's similar effectively, the similar effectivity with the start algorithm. So mostly Indonesia use this one to do the disaster triage. Okay, the point that they use to short the patient, it's also same that they saw from the fetal side. But in this one, they put addition like hemorrhagic or the chest decompression or available to transport or not. Okay, this is the familiar one. Start, yeah, simple triage and rapid treatment. I think that in Philippines also familiar with this kind of tools of disaster triage. Um, the color or the meaning of the classification color, it's same. Uh, Green is the, what's that? The better one, yeah. The people who can walk by themselves, and the people who cannot do this one will be divided into immediate, dead, or delight. We doing the assessment based on respiration condition, perfusion. Yeah, we back to the primary survey: airway, breathing, and circulation. Okay, this is explanation about the breathing, what should be considered, respiration, what should be considered, and the perfusion, what should be considered. They put that, remember, respiration, the, what's that? The point that we should give more attention is more than 30, and the perfusion more than 2 seconds, and mental status, they uh, cannot do uh, instructions. And then for the next, we will discuss or we learn about the how to do the disaster triage. We have 3 or 4 phases to conduct this one. Why? Because what I say in the first time, that disaster triage is not only conducted in hospital, but it mostly conduct in out of hospital or pre-hospital. So these phases explain about how to step bring the patient from the field to the hospital. The first is the primary triage. From the name you can see that this is the primary, so this is the initial, this is the first time we map the patient, and this is the first thing that we should do. The point or the purpose is to sort patient into triage categories. It's depend on the medical team response or the nurse, what they want to use, start or jump start or sako or other. But all of these tools is purposed to short patient based on their condition. And then in this phase, we also focus in physiology. Um, as we know, physiology focus in emergency aspect. It's called primary survey, airway, breathing, and circulation. And also in this phase, we doing the re-evaluate patient each time continuously, because the condition can be changed rapidly. The patient from the green color can be rapid move to the red color, or from the red they will move to the yellow. So in this phase, we doing what's that? Rapidly re-evaluate patient only in A, B, C. And then in this phase also, we, what is that? Mm, we make the decision. Is the patient upgrade or downgrade? Is they got better or they worsened? If they better, they can move to the other um, hospital or the medical facilities, or it will be they got the worsen. And then, yeah, in this phase, for the primary triage, the point is we sort the patient based on the condition. We use the color to what's that? To classify patient by the condition. Red, it means that emergence, and yellow urgent, not urgent, and expired. Um, and then after we do the primary triage, we move to the secondary triage. Secondary triage is mm, mostly conducted in hospital, but it also performed on scene. Maybe because the hospital or the facilities are not ready to receive the patient, so secondary triage happen in or perform in the skin. But the better one is the patient is soon transferred to the hospital. So in this situation, yeah, we perform on scene if delayed transport. Um, in secondary triage, we doing a more specific assessment. We call it a physical assessment and history. The previous one, we only assess airway, breathing, and circulation. But for this phase, we doing more. We do more. We call it secondary survey. So we can find another injury. We can find another condition. Even it's not treat the patient, but we have time to solve this one because if we wait hospital, maybe patient will be put in the bed situation. And then in this phase, we also doing the physiology reassess. Even we already move to the physical assessment or secondary survey, don't forget airway, breathing, and circulation can be worsened suddenly. So we should also doing the physiology reassess. And then after we doing the secondary triage, we transport patient to the hospital. Um, in emergency department. In emergency department, medical response team or nurse repeat the triage again. We call it secondary triage. So triage to it's done rapidly every time, anytime, anywhere. If we can do the triage, we doing triage again, triage again, triage again, because patient can change, the condition of the patient can change rapidly. And then short patient on needed and the available resources of the hospital. So in the hospital, they should know what their resources and what the patient need. If they can complete or fulfill the patient need, they should solve it as soon as. But if they have a limited resources, they should do the tertiary triage. What is the tertiary triage? Is a step from the hospital determine which the facility that can be what's that solve the patient, or which one the facility that have the higher level, complete more complete resources. So the hospital should soon transfer patient to another hospital. It's called a tertiary triage. The most common case later the transfer like multi-system trauma, burns, and spinal cord injury. For some hospital, they have no resources to solve this what's that this situation or this problem. Okay, if the patient has been what's that has been decide to should transport, mm, try to find out the effective resources. You want to transfer them by ground or by air transport. In Indonesia, I think that we are very rare use the air transport. We common use the ground transport. Even it take more time to transport patient to the hospital. And red patient will not the transport with the red one. So in the transport, you should make a pairing. Red patient will be paired by the green or yellow ones. It's not red and red. Yeah, two patients with the red trias will be transported to the same hospital because we what's that? We avoid or we should what's that? Anticipate that the hospital destination they have a limited resources. So the red patient will be spread to different hospital. And then if the disaster, the victim of the disaster are in a number of family, this one should be transported to the facility in the same facility. So if the victim is a father and son and their mother or their wife, this family should be transferred together in similar not similar. I mean the in same hospital. Uh, nah, in the some conditions, disaster triage it's not conducted by the medical response team because most of the patient arrive by their own. So they are not or they have not been triaged before. So it's happened, the first triage, it's happened in the hospital. Um, and then in the hospital should perform primary triage, secondary, and tertiary. So in one place or in one hospital, they should do the all of level of triage. That's all from my explanation. Hopefully, you get the better understanding about the what is disaster triage is, and because we have a limited time, hopefully my slide can help you understand what is the differences between uh, three or four kind of trias. Thank you for the time. Um, I will return the forum to the Mr. Satria or uh, who is lead this meeting, Mr. Satria. Okay.
Okay, thank you, Ms. Tika. Thank you very much for your
Yeah,
presentation.
you're welcome.
Um, Bu Kartika, Dr. Kartika, you are you here?
Yeah, Mr. Satria, Miss Nisa will start first.
Okay, I think you can start now, please.
Okay, thank you, Mr. Satria. Okay, I will share screen first. Maybe. Hmm, can you hear my voice?
Yes.
Okay, thank you. Yeah. Uh, wait. Hey, good afternoon, class. Today we're going to talk about triple burden of malnutrition, and I am Anissa Iningtyas, and I'm here with my partners, and I'm here with my friend Kartika Nugraheni, and today we're going to talk about triple burden of malnutrition, and we'll take turn in presenting these materials. And this is the outlines for today's class. Triple burden. First, we will talk about triple burden of malnutrition overview, and then cases, and then what can we do